This spark isn't sinus. Where did it come from? Unveiling Atrial Arrhythmias. Welcome back to Master the Beat. In today's episode, we're going beyond the sinus node and diving deep into the world of atrial arrhythmias, those heart rhythms that don't originate from where you'd expect. Atrial arrhythmias can be silent or life-threatening, and recognizing them quickly can be the difference between timely intervention and disaster. In today's episode, we will review the most common types of atrial arrhythmias: the Wandering Atrial Pacemaker, Premature Atrial Contraction, Non-conducted PAC, Paroxysmal Atrial Tachycardia, Atrial Flutter, and Atrial Fibrillation. From Basic EKG to Life-Saving ACLS, this course is designed to take you on a comprehensive journey from the fundamentals of EKG interpretation to the advanced life-saving interventions of the American Heart Association's ACLS guideline. Let's embark on this journey together and master the beat. Atrial arrhythmias arise from ectopic electrical activity within the atria, meaning the heart's electrical impulses are originating from sites other than the SA node. These arrhythmias can vary in severity, from benign conditions to potentially life-threatening scenarios, depending on how they affect cardiac output and lead to symptoms like palpitations, dizziness, or more serious outcomes. Let's talk about atrial pacemakers. The morphology of P waves can vary significantly depending on the pacemaker site within the atria. Let's take a look at some examples of atrial P waves displayed on the screen. Starting with the TP wave. In this example, the P wave is embedded within the T wave, often due to high rate of the rhythm. The next one is pointed P waves. Here the P waves are sharply pointed, which may be characteristic of certain atrial rhythms. The wavy baseline. This is a typical feature of atrial fibrillation, where the P waves are replaced by a wavy chaotic baseline. Right under the wavy baseline, the next P wave is a sawtooth pattern. This one is seen in atrial flutter, where the P waves take on a sawtooth appearance occurring at a regular rapid rate. Then we have the squiggle P wave. This is an irregular squiggly P wave showing abnormal atrial activity. Then we have the inverted P wave, an example where the P wave is inverted, indicating an ectopic focus in the atria. The Wandering Atrial Pacemaker. Before we move on, it's crucial for anyone studying biology, science, healthcare, or conducting research to understand the monumental impact of the Human Genome Project, or HGP. This international initiative dispelled long-standing myths about race-based medicine used still in today's healthcare guidelines and medical education. I understand. And I too found it hard to believe how much of what I once considered to be facts, evidence-based practices taught during my medical education and training as a critical care nurse, educator, and now as a provider weren't grounded in evidence. I get it. It's a challenging realization for any healthcare professional, but it's a realization that pushes me to continually seek and teach accurate research-based knowledge moving forward. That is why I started NovaMind LLC. Now, focusing back on the Human Genome Project, or HGP, its research started in 1990 and completed in 2003 and successfully mapped the entire human genome, sequencing over 3 billion DNA base pairs and identifying 20 to 25,000 human genes. This groundbreaking research reshaped our understanding of human genetics. To be clear about genetic variations within populations, all humans 99.9% are genetically identical. Biologically or genetically, race cannot be identified once the superficial phenotypical layer, like skin, is removed. Race was a made-up concept by human beings to promote racial essentialism from the colonial times. HGP results entail that most genetic variations, about 85 to 90%, occurs within these social constructs called racial groups rather than between them. This means that two people from what might be considered the same race can be more genetically different from each other than either is from someone considered to be of a different race. It's crucial that we move away from using race-based lab values, treatment guidelines, and medications. Instead, we must focus on individualized, evidence-based care that acknowledges the influence of social, environmental, and latest evidence-based research factors without relying on outdated racial constructs. The American Medical Association, or AMA, has a long-standing historical influence in racial essentialism in our healthcare systems today. I am pleased to note that the American Medical Association has recognized this evidence recently and developed policies to guide physicians and researchers in addressing it. While small changes have been made, we still have a long way to go towards fully dismantling these outdated practices and ensuring equitable, evidence-based care for all. Let's dive into one of the most mysterious atrial arrhythmias, the wandering atrial pacemaker. Now, don't worry, it's not an actual pacemaker roaming around in the heart. Instead, it's when different pacemaker cells in the atria take turns firing off impulses, each one trying its hand at initiating the heartbeat. Think of it as a game of musical chairs, but for pacemaker cells. The wandering atrial pacemaker is an arrhythmia where the heart's pacemaker site shifts between the SA node and multiple ectopic atrial sites. This results in a rhythm where the P wave morphology changes from beat to beat, reflecting that there's different locations from which the electrical impulses originate. The most notable feature of the wandering atrial pacemaker presents with 3 or more distinct P wave morphologies. These are variations in P wave appearance. The size, shape, or the direction of the P waves change across the rhythm strip. This rhythm is typically benign and often occurs in younger individuals, athletes, or during sleep as a result of increased vagal tone. While wandering atrial pacemaker is harmless, it can occasionally precede more serious arrhythmias, especially if the heart rate increases significantly. It is important to differentiate wandering atrial pacemaker from more concerning conditions like multifocal atrial tachycardia or atrial fibrillation, which has a faster heart rate and may indicate underlying pathology. On the ECG, wandering atrial pacemaker may have an irregular or regular rhythm. The heart rate is going to be between 60 to 100 beats per minute, or sometimes less than 60 beats per minute. It will have 3 or more distinct P wave morphologies. It will have variable PR intervals as the pacing shifts between different sites within the atria. The QRS is most likely to be normal at 0.10 seconds or less. Wandering atrial pacemaker clinical relevance. It is important to differentiate wandering atrial pacemaker from multifocal atrial tachycardia, which also presents with different P wave morphologies, but has a faster heart rate of over 100 beats per minute and may indicate more serious underlying conditions such as chronic lung disease or electrolyte imbalances. Wandering atrial pacemaker is a benign arrhythmia in most cases and does not require intervention. No specific treatment is usually necessary for a wandering atrial pacemaker. However, in older patients or those with underlying pulmonary disease, it could precede multifocal atrial tachycardia or even atrial fibrillation, which may require further evaluation and management. If symptoms arise or there are associated conditions, managing any underlying causes like electrolyte imbalances or respiratory conditions is important. Did you know? And just like the ventricles, the atria can also fire off early, causing premature contractions. That's right, premature atrial contractions, or PACs, can occur when the atria decide to jump the gun. Now let's dive deeper and learn more about PACs and how they affect the heart's rhythm. Premature atrial contractions are early heartbeat originating from ectopic sites in the atria. These premature beats occur when the atria depolarize before the next scheduled impulse from the SA node. PACs cause the heart to skip or jump, interrupting the regular rhythm, but the ventricles usually respond with a normal QRS complex. PACs are often detected incidentally on ECG, but they can be triggered by factors such as stress, caffeine, alcohol, and electrolyte imbalances. Although PACs are generally benign, frequent occurrences can indicate underlying conditions or lead to more significant arrhythmias, including atrial fibrillation or supraventricular tachycardia, especially in patients with underlying structural heart disease. Premature atrial contraction, ECG characteristic. The underlying rhythm is typically regular but becomes irregular when the PAC occur. The rate corresponds to the underlying rhythm unless affected by the PAC. The P wave associated with the PAC occurs earlier than expected and tends to differ from normal P waves in terms of size, shape, and direction. It may appear smaller, upright, and pointed, or in some cases inverted. Frequently, the abnormal P wave is concealed within the preceding T wave, which can distort the T wave shape. The PR interval is usually within normal limits, but may be unmeasurable if the P wave is hidden within the T wave. The QRS complex is premature, but typically has a normal duration of 0.10 seconds or less. PACs are typically followed by a pause as the heart's conduction system resets itself. There could be two types of pauses after the PAC. One is compensatory pause, and the second one is called a non-compensatory incomplete pause. To determine the type of pause after premature beats, measure the QRS complex before the premature beat to the QRS complex after the premature beat. Measurement equals 2 R-to-R intervals. The pause is compensatory. In the example strip, here there are 5 large squares between each R-to-R interval, and after the premature atrial contraction, the pause is approximately 10 large squares when measured from the QRS complex before the PAC. This indicates the presence of a compensatory pause. If the measurement equals less than 2 R-to-R intervals, the pause is a non-compensatory pause, and PACs are usually associated with that non-compensatory pause. PACs are usually asymptomatic and often detected incidentally on ECG. While most PACs do not require treatment, in some cases, frequent PACs can serve as a precursor to more significant arrhythmias, including atrial fibrillation or supraventricular tachycardia. These are especially in patients with underlying structural heart disease. Exercise-induced PACs can be more concerning as they may indicate underlying coronary artery disease or other cardiac abnormalities in certain patients. In symptomatic cases, management involves lifestyle modifications such as reducing caffeine, alcohol, and stress. PACs occur frequently, cause significant symptoms, or trigger atrial arrhythmias. Beta blockers or calcium channel blockers may be considered. For patients at higher risk of atrial arrhythmias, like those with a history of AFib, close monitoring with Holter monitors or further evaluation may be necessary. For rare cases where PACs trigger atrial fibrillation or SVT, catheter ablation of the ectopic focus may be considered. While PACs are often benign, frequent PACs or those causing symptoms should not be ignored, as they may be a signal increased atrial irritability or the potential development of more complex arrhythmias. Risk factors such as hypertension, heart failure, and coronary artery disease may increase the likelihood of PACs leading to further atrial arrhythmias. Just when you felt you knew PACs, don't let the unconducted PACs fool you to be an AV block. Unlike typical PACs, where a premature atrial impulse is followed by a QRS complex, unconducted PACs occur when the atrial impulse is blocked at the AV node, preventing ventricular conduction. Consequently, no QRS complex appears after the early P wave, resulting in a noticeable pause in the rhythm. This phenomenon is common in critically ill patients and requires careful interpretation to avoid misdiagnoses, as it can mimic more serious arrhythmias or blocks. In ECG interpretation, the unconducted PACs have an early P wave, typically seen often with a different morphology compared to the sinus P wave, indicating its ectopic origin. There's no QRS complex. Following the premature P wave without a QRS complex because the impulse fails to conduct through the AV node. Compensatory pause. The sinus node resumes its activity following the premature beat, and the next P wave will often appear on time as if the missed QRS complex had occurred. Key facts about non-conducted PACs. Non-conducted PACs are the most frequent cause of unexpected pauses in an otherwise regular sinus rhythm. They are often mistaken for sinus arrest or sinus exit block, especially when the P waves of the non-conductive PAC is obscured by the preceding T wave. To distinguish between a non-conductive PAC and either sinus arrest or sinus block, carefully examination of the T wave is essential. If the non-conductive PAC happens early, the premature P wave will alter the shape of the preceding T wave. In cases of sinus arrest or block, no P wave is generated and the T wave retains its normal contour without distortion. Our next arrhythmia is paroxysmal atrial tachycardia, PAT. Paroxysmal atrial tachycardia can occur due to various mechanisms, including increased automaticity of ectopic atrial cells, triggered activity, or a reentry circuit within the atria. Associated factors are common triggers include consumption of caffeine, alcohol, or tobacco, emotional stress or anxiety, and certain medications like albuterol, amniophylline, or digitalis. Underlying medical conditions such as chronic obstructive pulmonary disease, mitral valve disease, or digitoxicity are also known to precipitate PAT. PAT may occur in otherwise healthy individuals or those with heart disease. In individuals with normal cardiac function, this arrhythmia is generally well tolerated and may cause only mild symptoms like palpitations. The most frequently reported symptom of PAT, patients often describe a sudden onset of fast, regular palpitations, often without warning. The duration can last from a few seconds to several hours, depending on the episode's severity and duration. Dizziness is another common symptom due to the rapid heart rate reducing cardiac output, which leads to decreased cerebral perfusion. Patients may experience dyspnea, more severe in individuals with pre-existing conditions like COPD or heart failure. Patients, particularly those with coronary artery disease or myocardial ischemia, may report chest pain during episodes. It's usually described as a tightness or pressure in the chest. This is more likely in patients with underlying heart disease, severe hypotension, or those who are volume depleted. PAT characteristics on the ECG. Paroxysmal atrial tachycardia is a supraventricular arrhythmia originating from an ectopic pacemaker site within the atria, typically with a heart rate ranging between 140 to 250 beats per minute. PAT is frequently triggered by a premature atrial contraction and is characterized by its abrupt onset and termination, hence the term paroxysmal. PAT can manifest either as a sustained or continuous rhythm or in shorter intermittent episodes consisting of 3 or more consecutive beats. When 3 or more PACs occur at a rate of 140 to 250 beats per minute, this is classified as atrial tachycardia. Paroxysmal atrial tachycardia ECG characteristics. The rhythm will be regular. The rate of 3 or more PACs in a row would be between 140 to 250 beats per minute. The P waves will mimic TP waves. The PR interval is not measurable, and the QRS is normal at 0.10 seconds or less. A key ECG finding is that presence of the abnormal P waves, often hidden within the preceding T wave, which merge into a TP wave. Practice strip. Let's go through the rhythm analysis for paroxysmal atrial tachycardia step by step. We'll begin by identifying the key components of this rhythm on the ECG. Step 1. Rhythm. The rhythm in PAT is typically regular, and in our example, you can see that the R-to-R intervals are consistent throughout the strip. This indicates a regular pattern, which is common in PAT. Step 2. The heart rate in PAT is often between 140 to 250 beats per minute. In this case, the rate is measured at 170 beats per minute, which falls within the typical range for this arrhythmia. Step 3. P waves. Now, let's look for the P wave. In PAT, the P waves are often hidden within the preceding T waves. Because the atrial rate is so fast, the P waves are hard to distinguish, and what you'll often see is a merging of the P wave into the T wave, forming what we call that TP wave. This makes the P wave nearly invisible on the strip. PR interval. Because the P waves are hidden, the PR interval becomes not measurable. In this case, you won't be able to determine a clear PR interval because the fast atrial activity makes it impossible to distinguish where the P wave ends and the QRS complex begins. Step 5, QRS complex. Moving on to the QRS complex, we're looking at the width of the QRS to ensure that that ventricular depolarization is occurring normally. In PAT, the QRS complexes are typically narrow, indicating that the ventricles are conducting normally despite the fast atrial rate. In our example, the QRS complex measures between 0.06 to 0.08 seconds, which is within normal range. And in step 6, the ST segment and T wave. Finally, let's evaluate them. Even though the rate is fast, the ST segment and T wave appear normal in this rhythm, meaning there are no signs of ischemia or injury. This is common in patients with PAT unless there's underlying cardiac pathology. In this rhythm strip, we've identified regular rhythm with a rate of 170 beats per minute. The P waves are hidden, the PR interval is not measurable, the QRS complex is narrow, and the ST segment and T wave are normal except for that TP wave. These findings are consistent with paroxysmal atrial tachycardia. Now that we've analyzed the rhythm, it's important to consider treatment options based on the patient's symptoms and underlying conditions. ACLS guidelines for symptomatic PAT. It is essential before taking ACLS written test or megacode to be confident in identifying the correct algorithm for each rhythm strip that you analyze. This skill is not just for passing the exam, but it's critical in real-life emergencies where timely and accurate interventions can save lives. Knowing which algorithm to follow ensures that you apply the correct treatment based on ACLS guidelines. For instance, in cases of symptomatic PAT versus monomorphic ventricular tachycardia with a pulse, would we include the same intervention of adenosine or cardioversion? Using the wrong algorithm or interpreting the rhythm incorrectly in this same algorithm in real life scenarios could result in inappropriate care. For ACLS guidelines for PAT, you would use cardioversion and you may use adenosine. But if the patient is symptomatic, you would only use cardioversion for monomorphic VTAC with a pulse. You would not give the adenosine. Make sure to subscribe to NovaMind LLC membership to gain access to the exact ACLS algorithm for managing paroxysmal atrial tachycardia in emergent situations. In our members-only educational content, we cover everything from symptom recognition, medication dosing, to precise order of interventions, all aligned with the latest AHA ACLS guidelines. Don't miss out on the deeper dive into life-saving procedures tailored for healthcare professionals. Go to www.novamindllc.com. What are ACLS guidelines for symptomatic PAT? You would follow the tachycardia with a pulse algorithm key interventions. The first step is to determine if the tachycardia is causing significant symptoms that are indicating that the patient is unstable. Signs of instability include hypotension, altered mental status, signs of shock, ischemic chest pain, acute heart failure. If the patient is unstable, immediate synchronized cardioversion is required. Now, let's only focus on those symptomatic patients with PAT deemed unstable. For those unstable patients with a regular narrow complex tachycardia, which is PAT in this case, synchronized cardioversion is that initial priority intervention. You may also give adenosine, a 6 milligrams IV push rapidly, followed by a saline flush. If necessary, a second dose of 12 milligrams can be administered. Adenosine helps to terminate SVT by blocking AV nodal conduction. If adenosine fails or is contraindicated, consider beta blockers or calcium channel blockers, diltiazem or verapamil. Here is a free tidbit that I usually keep for my members only. Vagal maneuvers are more effective in treating sinus tachycardia, but are typically less effective for paroxysmal atrial tachycardia. Vagal maneuvers such as the Valsalva maneuver work by stimulating the vagus nerve to slow the heart rate. And they can successfully reduce heart rates in sinus tachycardia, but PAT often involves a reentry circuit, which makes it less responsive to vagal stimulation. For PAT interventions like adenosine, beta blockers, or calcium channel blockers are usually more effective. Next, we have atrial fibrillation. Atrial fibrillation, or AFib, is the most common sustained arrhythmia in clinical practice. It is characterized by a disorganized electrical activity in the atria, resulting in ineffective atrial contractions. This leads to an irregular ventricular response, which can cause symptoms ranging from mild palpitations to severe hemodynamic instability. AFib is associated with increased risk for stroke, heart failure, and all-cause mortality. In AFib, the normal rhythmic impulses generated by the SA node are overridden by rapid chaotic electrical impulses that originate from ectopic foci, particularly around the pulmonary vein. This leads to uncoordinated atrial contractions, especially the left atrial appendage, with ectopic sites within the atria firing at rates exceeding 400 beats per minute. The AV node prevents most of the atrial impulses from reaching the ventricles, allowing them time to fill, thereby protecting the ventricles from excessively high rate. However, the AV node conducts remaining impulses in an irregular manner, leading to an irregular ventricular rhythm that can affect cardiac output. In atrial fibrillation, when the ventricular rate remains below 100 beats per minute, it is referred to as a controlled atrial fibrillation. In contrast, when the ventricular rate exceeds 100 beats per minute, it is termed uncontrolled atrial fibrillation. The rhythm visually is easier seen more irregular with lower ventricular rates and less irregular when the rate is faster. In AFib, the atrial activity is so rapid that the atria quiver rather than contract effectively. This results in irregular wavy deflections on the ECG, known as fibrillatory waves or F waves, which affect the entire baseline. The atrial rate cannot be accurately measured due to the disorganized electrical activity. Occasionally, flutter waves can be seen along the fibrillatory waves, a rhythm commonly referred to as atrial fib flutter, indicating the presence of both atrial fibrillation and flutter waves. The hallmark of atrial fibrillation is the presence of that wavy baseline between the QRS complexes. The rhythm is controlled in controlled rates, grossly irregular, and in uncontrolled rates, it's going to visibly look more regular. Atrial rates, again, will be 400 beats per minute or more and not measurable on ECG. Remember, ventricular rate depends on the AV node. There's going to be a higher atrial rate than ventricular rate. P waves, again, would be fibrillatory P waves and present irregular baseline. QRS is normal and PR is not measurable. Let's try this practice strip. Step 1 is to analyze the rhythm. In atrial fibrillation, the hallmark feature is the irregularly irregular rhythm. As we move across the strip, you'll notice that the R-to-R intervals are inconsistent. There's no repeating pattern, which is characteristic of AFib. This irregularity is due to the chaotic electrical activity in the atria. Step 2. Next, let's determine the ventricular rate. In this particular strip, the rate is 60 beats per minute, which places the case in the category of controlled atrial fibrillation, meaning the ventricular rate is less than 100 beats per minute. Controlled AFib usually presents with a rate under 100, whereas uncontrolled is above 100. In step 3, now let's move on to the P waves. In atrial fibrillation, you won't see normal P waves. Instead, what we observe here are the fibrillatory waves. They create a wavy or chaotic baseline between the QRS complexes. Step 4, let's evaluate the PR interval. In this case, the PR interval is not measurable. This is typical in AFib because of the absence of the clearly defined P wave. In step 5, we look at the QRS complex. In this practice strip, the QRS complex duration is between 0.04 and 0.08 seconds, which is narrow and falls within normal range. This tells us that the ventricles are depolarizing normally, meaning the conduction through the bundle branches is intact. In summary, we are analyzing a strip with atrial fibrillation that is characterized by that irregular rhythm, the ventricular rate of 60 beats per minute indicating controlled AFib. There's F waves instead of the distinct P waves. There's a PR interval that is not measurable. We have a narrow complex QRS, approximately 0.08 seconds. These findings confirm atrial fibrillation with a controlled ventricular rate. AFib management. The primary goals in managing atrial fibrillation are controlling the ventricular rate, prevent thromboembolism through anticoagulation, and restore sinus rhythm when appropriate. Rate control is often the first step. It can be achieved with synchronized cardioversion or the use of medications such as diltiazem or beta blockers. If the arrhythmia has been present for less than 48 hours, it is generally safe to attempt the rhythm conversion with amiodarone or with electrical synchronized cardioversion. For patients whose AFib has lasted longer than 48 hours, anticoagulation should be initiated and a transesophageal echocardiogram (TEE) is recommended to rule out the presence of atrial thrombi before attempting rhythm conversion. This approach minimizes the risk of stroke. In cases of unstable symptomatic atrial fibrillation, usually associated with rapid rates of greater than 100, according to the ACLS TACI with pulse algorithm recommends synchronized cardioversion, and it's regardless of the time or duration of the arrhythmia. For patients with chronic or recurrent AFib, radiofrequency catheter ablation targeting the reentry circuits has shown high success rates in maintaining normal sinus rhythm. According to the 2020 European Society of Cardiology guidelines and the 2021 American Heart Association American College of Cardiology AFib guidelines, a comprehensive approach is recommended. Integrating care for AFib patients involving cardiology, neurology, and primary care to optimize stroke prevention, symptom management, and underlying disease control. Catheter ablation is increasingly recognized as an important intervention for rhythm control in patients who are symptomatic or have failed pharmacological therapies. Either intervention with rhythm control strategies has been shown to reduce the long-term risks of cardiovascular complications in certain patient populations. Next, let's review atrial flutter. Chronic atrial flutter is relatively rare and often converts spontaneously or after treatment to either atrial fibrillation or sinus rhythm. The rhythm is commonly caused by a reentry circuit. Atrial flutter frequently occurs following heart surgery and may also result from conditions such as valvular heart disease, ischemic heart disease, pulmonary embolism, and alcohol intoxication. When the conduction ratio remains consistent through the AV node, the ventricular rhythm will be regular. If the conduction ratio fluctuates, the ventricular rhythm becomes irregular. Pathophysiology of atrial flutter. In atrial flutter, the rapid firing of atrial impulses causes ineffective atrial contractions. The AV node acts as a natural gatekeeper, blocking a portion of those atrial impulses to protect the ventricles from those excessive fast rates. This is the same for AFib. The conduction ratio through the AV node varies, with a 2-to-1 or 4-to-1 block being common. If the AV node blocks impulses in consistent ratio, example 2-to-1, the ventricular rhythm will be regular. If the ratio changes, then the ventricular rhythm may become irregular. Atrial flutter arises from an ectopic pacemaker site in the atria, just like A-Fib, with depolarization rates between 250 to 400 beats per minute, commonly around 300 beats per minute. At such elevated atrial rates, the AV node typically blocks significant portion of the impulses, protecting the ventricles from excessively high rates. The AV node may conduct these impulses in varying ratios. The abnormal P waves, as seen in atrial flutter, take on the characteristic of a sawtooth appearance, referred to as the flutter waves or F waves. These waves dominate the baseline, eliminating the presence of an isoelectric line, and then often obscure the T wave. The most distinctive feature of atrial flutter is that sawtooth pattern between the QRS complexes. Atrial flutter ECG characteristics typically include the ventricular rhythm to be regular if there is a consistent ratio, or irregular if there's an inconsistent ratio. The atrial rate, as noted before, will be between 250 to 400 beats per minute. Ventricular rate depends on the AV node, but there will always be a higher atrial rate than ventricular rate. The P waves have that sawtooth shape flutter wave or F wave seen at the baseline. And then the PR interval is not going to be measurable, and the QRS is going to be most likely normal, which is 0.10 seconds or less. Let's begin analyzing this practice strip. Step 1. Rhythm. The first observation we need to make whether the rhythm is regular or irregular. In this case, the rhythm is regular. Both the atrial and ventricular rhythms are following a consistent pattern across the strip. Step 2. Atrial and ventricular rate. Moving on to the rates, the atrial rate is measured at about 430 beats per minute. This is characteristic of atrial flutter, where the atrial depolarization occurs very rapidly. The ventricular rate is 110 beats per minute. This results from a 4-to-1 conduction ratio, meaning every 4 flutter waves, there's only one impulse that is successfully conducted through the AV node, and it results in a QRS complex. Step 3. The P waves. They are flutter waves. There are 4 flutter waves for every QRS complex, and they exhibit that typical sawtooth pattern that is classic for atrial flutter. These waves are consistent in morphology and appear before each QRS complex, indicating a 4-to-1 conduction ratio. Step 4. PR interval. In atrial flutter, a PR interval cannot be measured because the flutter waves obscure the isoelectric baseline, and there is no distinct P wave preceding the QRS complex. Hence, in this rhythm, the PR interval is not measurable. Step 5. Now let's focus on the QRS complex. The QRS duration is measured between 0.06 to 0.08 seconds, which is within normal range. This indicates that ventricular conduction is occurring normally, without any evidence of a bundle branch block or conduction delay. In summary of atrial flutter with a 4-to-1 conduction, the rhythm is regular, the atrial rate is 430, ventricular rate is 110. P waves are 4 flutter waves preceding each QRS complex with a 4-to-1 conduction ratio. Our PR interval is not measurable. Our QRS complex is narrow, measuring between 0.06 to 0.08 seconds. This is a classic example of atrial flutter with a 4-to-1 conduction ratio, where the AV node blocks those 3 out of every 4 atrial impulses to protect the ventricles from excessively rapid rate. Complications of atrial flutter. Thromboembolism. Due to the ineffective atrial contractions in atrial flutter, mural thrombi can form in the atria, which increases the risk of stroke or pulmonary embolism. Heart failure. Persistent or rapid ventricular response in the atrial flutter can lead to heart failure or exacerbate pre-existing heart failure. Hemodynamic instability. Rapid ventricular rate may cause hypotension and decreased organ perfusion, leading to significant clinical deterioration. Management of atrial flutter. The treatment of atrial flutter focuses on rate control, rhythm conversion, and stroke prevention. Rate control. Controlling the ventricular rate is often the first goal. This can be achieved using beta blockers like metoprolol or calcium channel blockers like diltiazem. A free Novamind's members only exclusive trick, digoxin. Digoxin may also be used, especially in patients with heart failure, to slow that ventricular response. Now let's move on to rhythm conversion. Synchronized cardioversion. Atrial flutter is more likely to respond to synchronized cardioversion than AFib, and this is often the treatment of choice for symptomatic patients or those with rapid ventricular rate. Pharmacological conversion. Medications, such as amiodarone, can be used for rhythm conversion, though they are less commonly used in atrial flutter compared to AFib. Catheter ablation. In patients with recurrent or persistent atrial flutter, radiofrequency catheter ablation of the reentry circuit is highly effective and considered the first-line therapy for long-term management. Anticoagulation. Just like in atrial fibrillation, patients with atrial flutter are at increased risk for thromboembolism, particularly stroke. Apixaban and rivaroxaban are preferred over warfarin in most patients for stroke prevention. And that wraps up episode 7, where we explored the intricacies of atrial rhythms and how they affect the heart's conduction system. But we're not stopping here. Get ready for episode 8, Beyond the SA Node, the spark from the junction, where we'll dive into the fascinating world of junctional rhythms. What happens when the atria aren't in control? Where do those electrical impulses come from? Join me next time to find out. Remember, if you want more in-depth content and practice rhythm strips, become a member of Novamind LLC by visiting novamindllc.com or subscribing to our membership program on YouTube. Our members get exclusive access to additional content that's educational, helping you master EKG interpretation, much more. Thanks for tuning in, and I'll see you in episode 8. Don't forget to like and subscribe.